Every cell in your body relies on constant turnover, building up and breaking down large molecules. That breakdown happens here, inside the lysosome. Think of the lysosome as a high-pressure recycling center, packed with dozens of digestive enzymes. Each enzyme has one highly specific job: breaking a single chemical bond in complex lipids or sugars, dismantling the molecule step by step until the parts are small enough to be reused. But if a genetic mutation deletes just one enzyme from that sequence, the entire assembly line halts. The target molecule gets processed right up to the missing enzyme station, and it cannot move forward. Because the molecule has nowhere to go, it starts to pile up inside the lysosome, generation after generation, cell after cell. Over years, this accumulation physically distends the organelle and disrupts normal cellular function. This mechanism produces the specific organ damage we see in lysosomal storage diseases. Rather than viewing these conditions as a list of unrelated eponyms, clinicians can approach them as predictable traffic jams along two distinct metabolic highways. By mapping these two specific degradation pathways, you can deduce a patient's symptoms based on which molecule is being blocked and where that molecule normally resides in the body. This splits our targets into two families: sphingolipidoses for lipids and mucopolysaccharidoses for glycosaminoglycans. In the sphingolipidoses pathway, each arrow represents a digestive enzyme. The blocked step identifies the disease. To navigate clinically, start by checking for hepatosplenomegaly to immediately narrow the differential. Applying that single binary question splits the diagnostic group in half, providing a high-yield pivot point. Looking at the first step, we find Tay-Sachs disease, caused by missing hexosaminase A. Without it, the cell fails to process GM2 ganglioside. Because GM2 accumulates almost exclusively inside neurons, Tay-Sachs is a purely neurological disease, marked by progressive neurodegeneration, exaggerated startle response, and developmental delay. As lipid-laden ganglion cells pile up around the fovea, they obscure underlying tissue. The highly vascularized fovea remains visible, appearing bright red against the pale, lipid-filled retina, creating the classic cherry red spot. Because the excess lipid has nowhere else to build up, Tay-Sachs presents strictly without liver or spleen enlargement. Contrast this directly with Niemann-Pick disease. Here, the block occurs at sphingomyelinase, accumulating sphingomyelin. Sphingomyelin is a major structural component of cell membranes everywhere. It accumulates in both neurons and macrophages simultaneously. This means Niemann-Pick mirrors the exact retinal damage of Tay-Sachs, producing the same cherry red spot, engorging macrophages in the reticuloendothelial system to produce severe hepatosplenomegaly. Checking for enlarged organs separates them. Moving further down the map, we hit Gaucher disease. This is the single most common lysosomal storage disease, caused by a deficiency in glucocerebrosidase. Specifically, the unprocessed substrate, glucocerebroside, piles up directly inside the macrophages of the spleen, liver, and bone marrow. As they crowd the marrow, they disrupt normal blood cell production and bone architecture, causing pancytopenia and severe osteoporosis. Under a microscope, these engorged Gaucher cells take on a highly distinctive cytoplasm, routinely described by pathologists as resembling crumpled tissue paper. Next is metachromatic leukodystrophy, or MLD. The deficient enzyme is aryl sulfatase A, leading to accumulating sulfitates. Sulfatatides belong specifically within the myelin sheath, which exists in both central and peripheral nervous systems. MLD presents with simultaneous demyelination in both compartments, causing ataxia alongside peripheral weakness. Krabbe disease also attacks myelin due to a missing enzyme, galactocerebrosidase. However, the true culprit is a toxic byproduct called psychosine building up alongside. Psychosine is directly toxic to the oligodendrocytes that make central myelin. As they die, macrophages rush in, swelling with undigested lipid to form large, multinucleated globoid cells. The pattern holds. Whether a storage disease destroys bone architecture, visual acuity, or nervous tissue is strictly dictated by the biological home. There is one notable vascular outlier in the sphingolipidosis family, Fabry disease. It stems from an alpha-galactosidase A deficiency. You must remember Fabry by name for its genetics. It sits on the X chromosome, making it an X-linked recessive exception in this field. The target substrate, ceramide trihexoside, deposits heavily in the vascular endothelium. This progressive small vessel obstruction causes dark skin lesions called angiokeratomas and burning peripheral pain. Here on the right side of the master matrix, we switch substrate classes entirely. The mucopolysaccharidoses deal with the long sugar chains that form connective tissue. Both Hurler and Hunter syndromes result in the exact same dual accumulation of heparin and dermatan sulfate. Because these sugars exist throughout connective tissues, the presentation is broadly systemic: coarse facial features, airway narrowing, stiff joints. To tell them apart, look to the eyes. Hurler syndrome features distinct corneal clouding as sugars deposit directly into the stroma. Hunter syndrome involves a block one step earlier at iduronate 2-sulfatase. It is your second X-linked recessive exception and presents with zero corneal clouding. Recognizing the shift from purely neurological or macrophage-driven symptoms to broad systemic connective tissue issues immediately isolates a case to the mucopolysaccharide pathway. This decision tree provides a three-step framework for organizing the differential diagnosis. First, assess the presentation for hepatosplenomegaly. Its presence or absence immediately splits the possibilities between diseases like Tay-Sachs and Niemann-Pick. Second, scan for a single pathology buzzword. Look for crumpled tissue paper cells for Gaucher, multinucleated globoid cells for Krabbe, or corneal clouding for Hurler. Finally, verify the genetics. While most are autosomal recessive, Fabry and Hunter must be identified by name as X-linked exceptions. This matrix connects specific enzyme deficiencies to their genetic inheritance and defining clinical signs. While specific enzyme names and inheritance patterns still require precise study, mapping these pathways provides a logical structure for medical reasoning. Understanding the biological location of each blocked molecule explains exactly why a specific organ shows damage first.